Hello and welcome to day 3 of MedCity News' Invest conference. My name is Arundhati Parmar and I'm the editor-in-chief of MedCity News. We are gathering today after a momentous verdict from 12 of our peers in Minnesota that many believe is a small victory in the broader discussion of social justice and equity in our nation. But what about the implicit bias that's in our hearts? I may harbor some negative feelings without even knowing about them. The same is true of others. If I landed in the ER today, looking as I do, with the bindi in the middle of my forehead, a very well-intentioned healthcare provider may decide, oh man, she's fresh off the boat. We're gonna need an interpreter. So what happens when these implicit bias make their way into decision-making? How do we safeguard our AI algorithms from being affected by them? I'm, of course, making this discussion overly simplistic, so I'm very, very glad that we have an expert panel here today to discuss the very important topic of what is the role of AI in health equity. Our moderator for today's panel is Morgan Cheatham. Morgan focuses on applications of artificial intelligence in healthcare, marketplaces, and enterprise software. Before joining Bessemer, Morgan worked at Goldman Sachs in the consumer, retail, and healthcare group in the investment banking division. He also worked as a data scientist at Kairos, a healthcare IT startup focused on patient access and provider data management, and as an analyst at Rhode Island's Health Information Exchange. Morgan was accepted to medical school at age 17 and graduated magna cum laude from Brown University with a degree in neuroeconomics. Welcome to you, Morgan. John Bagby leads machine learning products in Mayo Clinic's ML Innovation and Enablement Group. His team applies a values-based system design approach that ingrains Mayo Clinic's values into ML initiatives and aligns to standards such as the Belmont Report and IEEE 7000. John is also a member of the Mayo Clinic AI Ethics Council. Before joining Mayo in 2019, John created award-winning products for 20 years in Silicon Valley for healthcare, enterprise, and consumer markets. Welcome to you, John. Tina Hernandez-Boussard is an associate professor in medical bioinformatics, biomedical data science, and surgery at the Stanford University's School of Medicine. Dr. Hernandez-Boussard's background and expertise is in the field of clinical informatics, epidemiology, with concentration in predictive analytics, population health, and health policy. A key focus of her research is the application of novel methods and tools to large clinical data sets for hypothesis generation, comparative effectiveness research, and the evaluation of quality healthcare delivery. Welcome, Dr. Hernandez-Boussard. Shiv Rao is the co-founder and CEO of Abridge, a company focused on bringing context and understanding to every medical conversation. Abridge uses machine learning to help people understand the details of their health, from the high-level care plan down to their details of their diagnosis, procedures, or medications. Prior to Abridge, Shiv led the provider-facing investment portfolio at UPMC Enterprises. He is also a faculty member and practicing cardiologist at UPMC's Heart and Vascular Institute and completed his medical education and training at the University of Pittsburgh School of Medicine and the University of Michigan. Welcome to you, Shiv. And last but not least, we have Webb Sun. He's the co-founder and president at Komodo Health, where he oversees operations including business development, sales and marketing, and people. Komodo Health applies artificial intelligence and other advanced data science techniques to its first of its kind healthcare map, which tracks the unique patient journeys of over 325 million patients. Prior to founding Komodo Health, Webb was a managing director at Zephyr Health, a leading life sciences data and insights solution provider. Webb also serves as an executive advisor to Refi Health, Heads Up Health, and other healthcare health tech startups focused on big data, SaaS, healthcare IT, and predictive analytics to improve patient outcomes. I also wanted to extend a big thank you to Webb and Komodo Health for sponsoring this session. So now I wanted to send this back to Morgan for the discussion. Take it away, Morgan.
Thank you so much for the warm welcome and thoughtful introductions. And again, thank you to everyone who's on the line for joining us today. We're grateful to have you here, and we're excited to have a dynamic discussion over the next hour. As you can imagine, we've prepared a number of topics for today's discussion, and we welcome you to interject at any time through the chat on Zoom to ask questions of our panelists. I'll keep my introductory remarks brief, but I just wanted to start with acknowledging that this conversation is timely for so many reasons. As a society, we are grappling with the COVID-19 pandemic, another public health crisis in the form of gun violence, and a racial reckoning that is exposing how systemic racism has embedded deeply within our institutions, policies, and practices, healthcare not excluded. And so we juxtapose many of these challenges with record levels of innovation in healthcare, nearly $7 billion invested into emerging technologies and digital health companies in the first quarter of this year, which is nearly the total amount invested in 2019. We juxtapose these challenges with a new administration that we expect to dramatically expand Medicaid and increase investment in home care via the infrastructure proposal. And we also juxtapose them with the recent interoperability ruling, which is expected to dramatically increase data liquidity across our industry, creating fertile ground for applications of computation in healthcare. And so our conversation today will explore the intersections of these trends and challenges. Now, I'd like to start with a question for Tina, and we'd like to start this panel off by establishing some common definitions. Much of your work leverages computational approaches to explore clinical and policy-related research questions at the population level, and in doing so, has played an integral role in establishing standards for safe and effective medical AI solutions. And so, Tina, I wanted to ask you, how can we think about defining and measuring health equity, and how much progress have we made in doing so?
Great. Thank you so much for this opportunity, and thank you, Morgan, for that question. So I want to kind of establish sort of the baseline here. Ethical analysis of technologies in healthcare demands that we take a view of fairness, or more appropriately, justice, that centers on the health and lives of people rather than the outputs of these technologies alone. So unfortunately, in the past, as we know, we've seen technologies that benefit a dominant population, which often leave underrepresented minorities at a disadvantage. And this is evident because of the lack of inclusion of diverse patients in clinical trials, in other types of research that bring us to these definitions. So this stresses the importance of sort of epistemic privilege, which is the idea that those outside of the majority or dominant group have knowledge that other insiders don't, and that bringing diverse perspectives actually enhances the quality and accuracy of the scientific questions we're asking, and helps us build trust across the communities. So while it's important that technologies have an equality focus, meaning that each individual member or group is given the same amount of resources, attention, or similar outcomes, there's also the question of equity, and equity suggests that each group is given the amount of resources needed to have similar outcomes. So understanding how to develop technologies and implement a technology that provides both equity and equality really presents a paradigm shift in the way we think about resource allocation in healthcare delivery. And to measure health equity, we need to have standards that require technology is tuned to fairness, meaning technology results in group and equalized fairness, equal rates of false positives or false negatives across what they're looking at, as well as overall accuracy and treatment equality. So in my experience, this can only happen when we really have the community come together and adhere to standards and what we see coming forward.
Thank you, Tina, and so many good threads in your introduction. We appreciate you laying that groundwork for us. I want to start with the upfront comment that you made around the need for data assets that actually reflect the populations that we're serving. And I'll pass this question to Webb because Komodo applies many computational techniques to vast and multimodal data sets to surface these signals for population health implications. And I want to hear from you, Webb, how does Komodo approach evaluating the diversity of data? And in your mind, what are some of the current limitations that we face in the data assets we're using today?
Great. Thanks, Morgan. And thanks, Tina, for that setup as well. We've always started with this belief that AI is only as good as the data it's built on, and AI innovation needs to be built on a canonical view of patients and all of the actors around those patients. And so regarding the importance of evaluating diversity of data, an important starting point is looking at demographic data, social determinants of health, as an example. Where do patients live? What are their ages, ethnicity, socioeconomic status, et cetera. Then we want to understand the entirety of the patient journey and having insights into every clinical encounter with the healthcare system. What providers are they interacting with? Within what settings of care? What diagnoses are being used? What tests, what procedures, what therapeutic interventions, and how all of that is being sequenced is a meaningful part of understanding the entirety of that patient journey. And then having that patient complete understanding of the individual patient experience and marrying that up at a more macro level understanding of population health allows us to reflect the epidemiology of disease as well as the individual experiences of the population. In contrast, not seeing a patient complete picture of these individual patient journeys inherently biases cost and outcomes related studies. And in addition, the corresponding AI that's being developed can be fundamentally biased, as if you think about it, a lot of the traditional legacy data sets powering these kinds of analytics tend to either be incomplete or biased towards commercial payers and their member populations who are oftentimes healthier and wealthier. So all of this is really serving to reinforce inequities in healthcare delivery and the corresponding approaches towards improving patient outcomes for the entirety of the population, and particularly those most in need.
Those are great points. And I don't know, as a follow-up, Webb, if you can share, but I'd be curious, where do you look for data assets that might be more complete? And obviously as an early stage company, when Komodo was just starting out, you potentially couldn't have gone and bought, the most robust claims assets out there. And maybe those that actually a lot of academic institutions have access to. So are there any hacks for this kind of thing, or does it just take time?
Actually, Morgan, I think that's a great point. And I think that also speaks to the challenges of taking on something this important. Is most of the approaches previously have been hacks. The people doing the work on cost and outcomes were doing it on whatever data they were able to hack their way into. And what we've taken is this expansive approach towards saying, we want to understand human health. We want to be able to see what's happening across every patient in the healthcare system. At this point, we're looking at and tracking longitudinal patient journeys for over 325 million patients through real world data. And stitching that together is probably the biggest, most complex, most important challenge that we've undertaken. And I think it's what has allowed us to not have our AI be powered by, hacked, substandard, biased, incomplete data sets, and instead have a more comprehensive understanding of human health and what we can do to ensure that, we are delivering the right kinds of recommendations to the system.
That's a great point. That's a great point. And I think actually is a natural segue to talk about some of the work that Shiv is doing and at Abridge in particular. Shiv, Abridge is built on the fundamental premise that most of healthcare delivery begins with this conversation between a patient and their clinician. What signals can we distill from novel data assets such as those that Abridge captures? Maybe you can tell us a little bit more about how you guys are doing that. And how do you think about bias across the stack?
Yeah, so like you said, at Abridge, our mission is really to do two things for people, to help people better understand their health and to help them better follow through on their health. But the thesis that underpins that mission really is that, especially for people who've got something going on, like a chronic condition or multiple comorbidities, upstream of all the diagnostics and therapeutics in healthcare, there's a conversation. It's spoken. The signal is audio. So our position of being person or patient-centered makes it really important for us to think about bias and issues around health equity up front. And when we think about the stack, there's an excellent review article by Irene Chen. I think it's called Ethical Machine Learning in Healthcare, where she breaks down and others break down how the stack or the chain looks something like defining the problem. Like the problem selection itself can have incredible amounts of bias associated with it. Then you move on to data collection. And Webb broke down a lot of the issues related to that. And then we get to outcome definitions. And then we get to the algorithm development, where I think we read so much, but there's so many issues that are actually upstream of algorithm development. And then there's those post-deployment considerations once the algorithm's actually in the wild, and thinking about how do you keep track of bias, even there, in terms of like who's getting afforded access to it, those user experiences. So it seems to me that like the more the lower in the stack the bias is sort of concentrated, the more dramatic the downstream sequela can actually be. And so thinking about the entire stack and how you're going to tackle it, all the way from sort of at least acknowledging like the sort of systemic biases that could be informing problem selection or problem definition is really, really important. So in terms of the core signal at Abridge itself, medical conversation audio, it's distinct to us because it's really upstream signal. It's signal that's upstream of the electronic medical record, for example. And the nature of it is it's really rich. You know, audio, that interaction, it can go from one end of the spectrum around like voice and sentiment and like voice as biomarker sort of signal, all the way to conversational analytics like talk time, related to how much the clinician spoke, how much the patient spoke, the total length of the conversation, how many turns were there, how many interruptions, how many big words, medical jargon was used. And then I think like there's another layer, and the other layer that where we're really focused from a research perspective and from a product perspective is really on the language and the content of the actual conversation. So being able to extract information related to symptoms, diagnoses, procedures, medications, and then also all the surrounding context is where we focus our machine learning. And so when we think about framing challenges, we think about our data set, we think about historical bias, representation bias that we've kind of touched upon already. We think about annotation bias because we have experts for these fully consented data sets. We have experts actually annotating the data, and who are these experts and what are the guidelines, and then how are we measuring, and then how are we evaluating? So there's a whole stack again, I think, in terms of thinking about bias in relation to the data set.
I think that's a fascinating point, and you know, alludes to the compounding effects that a lot of this bias has at varying levels of the stack, as you point to, and as Tina mentioned, so much of the assets themselves inform the questions, and so you get this really challenging feedback loop when you don't have the proper assets to inform the right questions. And actually, I think, you know, that's an interesting point that I'd love to dive deeper into, especially as we think about some of the statistical measures of health equity that we're all striving to define. This notion of data quality and completeness. And I want to pass this one to John. Obviously, just given the work that Mayo is doing and the recent announcements around the platform that you all are building, you know, what is Mayo doing at this point in time to establish fairness in healthcare training data?
Thank you very much, Morgan, for inviting me and for the great question. It's great to be here. It's a very humbling experience working at Mayo Clinic. You know, I'm very excited about some of our advancements, and I do think that the advancements are rooted in basically our organizational ethos for the last 130 years. We're a values-based nonprofit, and the needs of the patient come first in everything we do. So no matter what our efforts might be, commercial or otherwise, we're always grounded in that value. And then there's also the rich ties. That's an acronym for respect, integrity, compassion, healing, teamwork, integrity, excellence, stewardship. We're all evaluated on those rich ties every year in our employee evaluations as well. So there's a real commitment historically and day to day to doing the right thing. And the amount of empathy at an organization like this allows us to approach data, training, validation, any set of data from a holistic perspective. And so I would start to answer that by kind of dovetailing off of something Shiv was talking about the context around the conversation. So for us, a lot of times, machine learning is all about allowing that conversation to be more eyeball to eyeball. taking some of the cognitive burden away with decision support tools, for instance, teeing up the right conversations in advance. And that context can only be established by looking at it holistically. I think a lot of the first mistakes out of the gate with us and other folks were, well, hey, the model seems to work. It's going to be successful. And that is, there's brilliant people that go, into the data science aspects of statistics and modeling with great data sets and great tooling for making sure you're training with good data. But what we try to do is actually send in anthropologists, send in ethnographers, which is a type of anthropology, to understand that conversation, to understand the population that will be impacted, like someone else was talking about earlier as well. Upstream as far as possible, when the idea is just a glimmer of what we might want to build to augment the practice, to make sure it doesn't disrupt safe, ethical clinical practice. So there are, this holistic perspective, I think, informs the entire team that's building the model in ways that they might not have thought of otherwise. The social science aspect, really the empathy. Those of you in Silicon Valley know the whole design thinking tension between kind of a product need, a technical constraint, and the empathy for the person it will impact, the product will impact. We're trying to bring that perspective upstream to creating models. And then when we get to the more technical, the proactive techniques and the things we're measuring and how we monitor for those measures, we're able to ground those as well. Finally, I would say, there's some very exciting standards that we're trying to leverage. Not just some of the medical standards that speak to justice, for instance, the Belmont Report, which is a result of Tuskegee experiments and some unethical practices that I'm sure our physicians are more familiar with than I am. But then the more technical ones, like the IEEE 7000, which is ethics in action for system design, which is a pretty holistic view. And then even more recently at the Consumer Electronics Show about a month ago, a new ANSI standard was released, an American standard around trustworthiness in AI. And that actually speaks to user experience and to upstream human trust, as well as the technical validation trust and testing your training and validation data sets for bias. So all of these standards, along with our own institutional values, really do keep us grounded and humbled throughout the process. And we try to remind ourselves that this is all so new and nobody's really getting this right. And there's so much hype. And that the Gardner, I think the Gardner hype cycle has digital ethics at the very top of that cycle, if you're familiar with that graphic. And just trying to remember that there's a real impact here, 2, 3, 4 ripples of impact beyond what we might think of when we're just building a model.
Thank you, John. And I think one thing I'm really hanging on to from your comments is this notion that this is a very new category relative to others in healthcare. And for the first time, folks are going to school, majoring specifically in computational biology with the intention of entering this new field. And it strikes me that we kind of have this birth of folks who are bilingual or multilingual in nature. They speak the clinical aspects of this field, but also the computational. But your point is a good one, that we also need to further encourage these folks and support them in pursuing the social sciences and really elevating that in the curricula that we design for this area. I think it also reminds me of some of the work, and to pass it back to Shiv, that you all are doing, from an ethical perspective, interrogating these concepts of fairness and bias in the patient-physician encounter. I know you all have published extensively on medical conversation AI as a company, and I'm sure some of your findings have been at times challenging to sit with. And so just kind of would love to hear you opine or share what are some of the things that your team has uncovered, and what are some of the ethical questions that have emerged from these insights?
Thanks, Morgan. One of the focus areas for machine learning at Abridge is to help people better follow through on their next steps. So on their care plan, essentially. So that for us from a research perspective has involved a data set fully consented by all parties involved in the conversation that was de-identified and then annotated over years so that we can train models against them. But this data set has a lot of metadata associated with it that allows us to really start to interrogate questions around bias and around fairness. So from a research perspective, when we defined one of the initial explorations in this area was that we sort of posited that the plan, this assessment and plan or plan classifier that we were training provides a benefit to the patient, that when an end user using Abridge is able to very quickly sort of decipher what the next steps are in their care plan, and then we can use that information to remind them with the audio, with the voice of their clinician about their next steps, that that's a benefit. And that if this benefit is not allocated equally across groups, then there's unfairness. And so one of my colleagues at Abridge, Elisa Farrakane, is a PhD in linguistics and machine learning. And for this space, despite all of her depth, this is brand new work. This space in terms of research, especially around medical conversations, there are really no standards here. There's no pre-existing work. So there was a lot of from the ground up sort of first principle thinking to establish some scaffolding to be able to learn more. Because the idea really is we wanted to be able to ship this value to everyone, not just specific people, not a specific segment of society, but everyone. So what we found in one specific study, and the paper is on arXiv, like you mentioned, was that there were small but statistically significant differences in how that benefit around that plan classifier is allocated to some groups. And the takeaways for us, I think at the highest level, are that number one, our data does not perfectly reflect the real world. That's just sort of a problem that I think any data company has to deal with, but being able to kind of confront it and then put together strategies to sort of tackle it over time, I think is really the key. And then number two, we learned that our data has differences across populations. So it's important to understand where our model is lacking in data so that we can make plans then to address that issue and really augment our data set so that we can do a better job for everyone that's out there.
Thank you, Shiv. And I think the point that you make around these algorithms offer us these insights that are intellectually interesting and in theory supposed to be applied to those next best steps or next best actions, the downstream clinical workflow. And that's an area that I'd love to focus our conversation on, zooming out and thinking about, how do we actually leverage these insights to impact outcomes. And so with that, I'll pass it to Tina. I mean, we'd be remiss not to mention COVID-19 and the role that the pandemic has played in shedding light once again on the racial, ethnic, and socioeconomic health disparities that have existed for a long time in the US. And Tina, I'd love to hear your perspectives. I know you've published work on this topic. How does bias manifest in our epidemiological models, specifically for COVID-19? And what impact does this bias have on downstream care and ultimately resource allocation?
Great, thank you. That's a great question, and you're right. We cannot have a conversation today without mentioning COVID, and so it has been very clear that COVID-19 has had disproportional impact on minorities in terms of infection rates, hospitalizations, mortality, and I think that at the beginning of the pandemic, we were so desperate to understand the disease and understand how to treat the disease that there was this flurry of technologies that came out into mainstream, into the literature, that were actually eventually retracted, a lot of them, because they were based on very small samples, unrepresentative populations, and they had real issues with biases in the data. And these technologies can cause serious harm to certain populations, really exacerbating these disparities. And so, however, you need to think about in this situation with COVID-19, where it's a very novel disease, we have to balance innovation and insight with fair technology. And that's a really hard thing to balance, right? And so one of the standards that we proposed, as you mentioned, is the MIDI-MAR Stanford, which is the minimal information for medical AI reporting. And in that suggested paper on standards, we talk about really when you're developing these technologies and you're disseminating these technologies, you need to have a full description of the training data, the model architecture, as we've all mentioned on this panel today. Because I believe that while no data set is perfect and without biases, transparently reporting that information and being very clear about where your training data is coming from allows the technology to be appropriately used and applied to the right population, right? And so we're giving these to clinicians, to healthcare systems. There's a lot of smart people on those teams. And so if we're very clear and transparent about what this data, what this technology was trained on, what it's applicable to, it can be appropriately used. And I think it's important to understand that when we don't take biases into consideration, the technology doesn't harm just an individual, it harms entire populations. And we need to think about how we can balance this innovation and technology between the provider, the patient, the healthcare system, and the informatician. And by clearly reporting on a set of standards, I think we move forward in that direction.
It's fascinating work. And I think the call for transparency generally is in complete juxtaposition with what many of us have seen, which are black box models operating in the wild. And I think for a long time, we comforted ourselves with these models because we said, well, the machine learning folks will focus on this. And again, as we talk about this birth of bilingual and multilingual stakeholders who speak both languages, clinical and computational, I think we do away with that black box operating model for good. I'm curious, for our other panelists, what are some of the things that you've done to kind of increase the transparency of the bias in the data assets that you all are working with, or what are some best practices that you're honing at your organizations?
Well, one thing I would highlight that we've done here is when you have incomplete data and when you know your data set is inherently biased, oftentimes the way that many historically have addressed this challenge is by projecting data. Well, when you project, all you're doing is exacerbating the bias that's already inherent in your core data assets. And so one of the things that we've undertaken at Komodo is just to ensure that everything that we do within our healthcare map is largely powered by raw, unprojected data, all de-identified, anonymized, and tokenized, but on the individual patients. What that allows us to do is, systematically identify gaps in our healthcare map, address them over time. And this speaks to one of the questions you were asking earlier, Morgan, around how do you continue getting a better and more representative and more diverse understanding of healthcare? Well, you do that by proactively identifying and addressing the gaps in your core assets that are powering, the cost, outcomes, analytics work that you're doing. And the way we've done that is essentially by using unprojected data within our healthcare map to then power the AI that we develop and the recommendations that we surface to our partners.
It's a great point. It's a great point. And I guess I'd also I'd love to hear, John, do you think that you have any thoughts on this point? I mean, for some of the technology companies that we're mentioning on this panel, folks can kind of nimbly reach out and acquire assets to bolster the data sets that they're working with. In a hospital system setting, it's brick and mortar, you have a flag in the ground in a specific market and geography, and you can't necessarily change the folks, the profile of the folks who are walking through the door without, expanding. So I'm curious, what are some of the things that Mayo is doing to again, fill in the gaps in the data sets that you all are working with?
That's a great question, Morgan. Yeah, I mean, we started as a upper Midwest, Rochester-based hospital. Although we actually do have two other pretty large hospital sites, one in the Phoenix, Scottsdale area, actually two there, and one in Jacksonville, Florida. So we do get a much more expanding patient base as our health system expands. As well as some international expansion that we've been doing. And we've been really committed. I mean, I've only been here 2 years, but I've just seen the curve of our leadership, our outreach to making sure we're not just tailoring our approach to the top of the patient pyramid, those people that fly in on their private jets, but socioeconomically across the entire health system, and especially in rural health. So that's a huge evolution for the organization over time. And again, I think it speaks to the empathy that's ingrained in our culture, and also some of the generational turnover. I'll be frank. I think as the younger leaders come into play, they're aware of the issues around equity, and equity isn't one of our values, but it's something that needs to be addressed. So that's, I think, in a lot of the forefront of a lot of our new leaders' minds. And then tooling. There's we've got a new partnership with one of the examples is Denodo. So data visualization into the data that we're using from the record. We've also switched to Epic recently, and there's a publicly announced relationship we've got with Google Cloud for some of our experiments, natural language processing. And so the tools that are available to us from some of our best of breed partners allow us some insights, again, upstream, before we deploy any tools into the wild. We use the toolkit at hand to really robustly look at, again, training, validation, independent validation, et cetera.
It's fascinating, and I think one thing that you mentioned which is interesting to me personally, is the notion of international expansion, and I do want to focus some of our conversation, because we're coming up on we have about 20 minutes left, on the systemic impacts here. But before we move on to that point, and maybe Webb and Shiv, would love to hear your thoughts on like developing models in the U.S. I mean, we are in theory a relatively heterogeneous society. I think, accessing that heterogeneity and tapping into it is challenging. But can you talk a little bit more about how you think about, the exportability of some of the models that you're developing on a global scale?
Shiv, it's up to you. You want to go first? I'm happy to jump in, but I'm worried that I've talked a lot already.
No, and I'll pass the mic over to you in short order. I think in terms of exportability, there's a process that we have in place where we build a model, we sort of test it, we validate it. Oftentimes, before we'll deploy a model, we'll publish a paper about that model to be sort of transparent with ourselves. And hold ourselves to a certain level of rigor, but also transparent with the community so that others can kind of hold us accountable. And so hopefully we can also add to the community's collective sort of knowledge about anything. And then I think what happens afterwards is something that I think any company in the machine learning space probably has to think about, is like, how do you think about audits? How do you think about, once you've deployed something to the market, like how do you make sure to build into your processes ways to look back and reflect and make sure that you're assessing and being honest in terms of the actual subsequent and the impact of what you've created in the wild. I think your point about the United States and the heterogeneity in the data is great. I think this is like an incredible sandbox for us to be able to gather data, to be able to build models that can hopefully generalize. But I think like without kind of upstream recognizing that you've got those gaps and understanding where they are, it can become really difficult to pause, audit, go back, reassess, and reconfigure.
Absolutely. I was also going to say, we always bring it back to what is the use case? What are you trying to achieve? What is the outcome you're driving towards? And to your exact point, when you have the heterogeneity of the US population that we see, that gives you a lot of power, right? It gives you a lot of ability to understand what's happening. And if the use case here is better understanding, better ability to proactively address inequities in healthcare delivery, then obviously you need to be able to see what's happening across the entirety of the healthcare system, which is part of the reason why we've been making this drive to understand and to really track census in terms of every single person interacting with the US healthcare system. One other thing that we've done that I think speaks to the power of software is we've created what we call a universal patient cohort creator. And what that allows us to do is to look at the entirety of our healthcare map and really pinpoint the patient populations that we want to deep dive into, the patient populations that we believe may be underserved or be receiving substandard of care, that may be experiencing poor health outcomes. The way to do that is to be able to see things at a population health, at a census level, but then also be able to drill down to explore different populations. And so, this is really the exciting point in time where we see the intersection between, to your point earlier, ever increasing liquidity in healthcare data paired with, computational advancements, paired with, an understanding of the kinds of new use cases that can be powered through software and through analytics and through AI.
That's great. That's great. And thank you for both for sharing your perspectives on that one. I think it's one that we're still seeing play out. And I think the same is true for, again, how we translate the findings from these models into, downstream boots on the ground, clinical, impact. And, I'd love to tee this question up for John, and Tina would also love to hear your perspectives as well. But John, Mayo Clinic continues to be one of the most innovative health systems in the world. And despite new innovations and medical breakthroughs, and candidly extensive research on health disparities and health equity, we collectively remain behind on translating a lot of these findings into improved outcomes for at-risk populations. So we'd just love to hear your perspectives on where do we start in bridging that gap from computation to outcomes.
Yeah, that's not a softball, Morgan. That's a hard question.
The others can chime in too. We'll group think.
Yeah, no, I mean, some of the things I've said already, world-class partnerships, making sure that we're really grounded in standards, not just the principles that we are proactively establishing how and when fairness happens, but the techniques employed for measuring and monitoring those measures. I think someone put in the chat, Dr. Hernandez-Boussard put a new standard, a new publication in the chat box, which seems to be very practical, very grounded. And so that's the kind of thing that we're very attracted to. So we're trying to keep we're starting by keeping world-class conversations going. I'm staying on top of the emerging standards like the trustworthiness in AI standard I mentioned earlier, like this one that was just posted in the chat. Again, that IEEE 7000 that really gets to issues of human rights and transparency and agency that offer a sense of techniques to establish, as the one standard says, human, technical, and regulatory trust, actual tactical techniques, not just aspirational principles. And it feels like every couple of weeks, there's a new set of more nuanced, more grounded standards that someone is releasing somewhere in the world. So I'm staying on top of that, learning from that in industry as well as in academia.
That's great. And Tina, would love to hear your perspectives on this one. Maybe I'll also just throw in, I would love to just hear how you think about the change management required. I mean, standards are great. And I think in the clinical practice of medicine, we are good at adopting and deploying standards to an extent, as we've talked about throughout this panel. But what is also required from a human capital change management perspective to actually implement some of these standards?
Yeah, that's a great point. And as was just mentioned, I mean, standards are coming out almost weekly. We're seeing new standards, a lot of overlap. And so how do you know which one is the right one? How do you know which one to follow? And that's, a really hard question. And so, I'm going to date myself a little bit by saying, when I started my career, it was the explosion of gene expression data, right? And it was the wild, wild west. And so it wasn't until we started developing standards and the journal editors and NIH and these other big stakeholders started to say, we're not going to publish unless you abide by these standards. We're not going to fund you unless you deposit your data into this particular repository. And so really you need to have these very, national level leadership identify which standard is right. I mean, we have the FDA who came out recently in in January stating, that they're going to pull back on pre-market evaluation for software as a medical device for a lot of these, mostly radiology, but some AI technologies, because they said, there's no evidence that there's individual harm from these technologies at the individual level, which goes back to my point I made earlier. We're not harming at an individual level, we're harming at a population level. And so really getting buy-in and leadership on what is the right set of standards to move forward with is really going to help that. And COVID is a great example where we had all types of technology coming in, trying to understand who's getting a ventilator, who's getting at the beginning of the pandemic. And, a lot of the algorithms that we were seeing at Stanford, were really, well, if you are obese or if you have this type of cancer diagnosis, which was really unethical, and we could not implement that. And so it's through having these, as was mentioned, these multi-stakeholder perspectives to help guide. And it's not an easy conversation. And it's not a conversation that happens in a week or a month or even a year. It is a very slow turning conversation. But I think that COVID has really put this conversation, as other things in the nation, on sort of steroids. And we are really moving through the system a lot faster. But it is high level leadership and really identifying a standard that we can all agree upon, which is difficult.
Definitely. And also, I think, whose responsibility really is it to shepherd the standard through the system? I think, this panel is reflective, I think, of various stakeholders in the healthcare ecosystem, on the research side, obviously, within the health system, and on the innovative technology side. And I think for a long time, we also just didn't have that person who was the custodian of this work from an implementation perspective. And it's encouraging to see that changing. But I guess along that point, we have a really thoughtful question from the audience just around national health associations. What is their role? Ellen provides examples, the American Cancer Society, for fitting AI into the picture. And in my mind, also very much evangelizing these standards with clinicians. So welcome anyone on the panel to take this one.
I think one potential role is to fund more clinical research to sort of expose the structural bias in place that's inherent in a lot of the eminence-based guidelines and even evidence-based guidelines that we practice against every day. I remember from early in my training, New England Journal of Medicine article that was called "The Effect of Race and Sex on Physicians' Recommendations Around Left Heart Catheterizations." And in that study, it was a really kind of interesting kind of design where they put in front of varying clinicians, I think actors, relaying stories about their chest pain, to see how the nature of the background of the actor and the way they were telling their story could impact a clinical recommendation. And African-American females were the least likely to get recommended the more invasive procedure to arguably more definitively fix the problem. And so that's not directly, that's not directly related necessarily to machine learning, but I think it does expose an opportunity, which is, that was in 1999. And I think that there's been more research in the space, but there could be a lot more research in the space. And it could be across all of the different sort of clinical verticals out there, so that these sorts of, this sort of data gets integrated into our practice guidelines, and they're more top of mind on a daily basis in every clinic and every hospital out there.
I would just like to follow up on that, because these national associations, et cetera, they can help fund research on this particular topic. What I would like to see is more broadly that any research that's coming out actually has some form of addressing systemic bias or understanding bias integrated into these larger research grants. And I'm on a couple advisory committees where they're thinking about, on a typical R01 grant, for example, you have impact, you have significance, and there's discussion, do we need a special section on, addressing systemic bias? And I think that would be a great step in the direction to have everyone just really think about this question and this problem in every aspect of research, not just research focused on this topic, but every aspect.
I was just going to add, at Komodo, our mission is to reduce disease burden. And through that mission, we work and address that mission through multiple partnerships across different actors across the healthcare system, including patient advocacy organizations. And so the reason why I bring this up is I'll share a small but very personal anecdote on how bias can manifest in terms of opportunities. I've had multiple instances where, because of my connectedness, my organization's connectedness with different parties, whether it be patient advocacy groups or enterprise life sciences companies or diagnostics companies, people reach out to me and they say, hey, I have a friend who has this rare, genetic defect and their child will potentially go blind, but I know people at such and such company. Can you help introduce me so that we can figure out where their trials are? Or frankly, they've personally done a lot of research on their own because they have the ability to, the knowledge, the accessibility to that information to go look at ct.gov as an example. And when I think about the possibilities of partnering more aggressively and expansively with patient advocacy organizations, they have their own registries. And oftentimes what they're really looking for is more connectedness across the ecosystem to surface more of those opportunities to the patients that need it most. And so when you think about it, bringing those opportunities to light is a huge challenge for us and really speaks to people having visibility, people having understanding, people having, the data and the recommendations that are required to be able to participate in these kinds of, potential therapeutic innovations.
Thank you. These are all fantastic points. And in the interest of time, I think we can field one additional question from the audience, and then we'll go into our last kind of rapid fire question for each of you. The question is from Sharon Jackson, and she asks, additionally, are HEDIS and NCQA guidelines being amended to include health equity metrics and parameters that can be incorporated into value-based contracts? And I open the floor to anyone to dive into this one. It's a critical question. Or should they? I could rephrase, should they?
Absolutely. I think it would make all the sense, and it would be really an inspired kind of HEDIS metric. And I think given the nature of how HEDIS works and how it's sort of a threshold sort of framework that plans have to meet, I think it would really raise the bar across the entire ecosystem to be more mindful.
Great. We welcome the audience to chime in with anything else. Otherwise, we will proceed to the last rapid fire question, our closing question for our panelists today. I think in summary, there are many people listening right now who sit across the ecosystem who are either operating or investing in healthcare companies where data and AI play a key role in the product and business strategies. And so what is one piece of advice that you'd like to share as we embark on the collective journey to build a more equitable healthcare delivery system? And maybe we can start with John.
I'm sorry, could you repeat the question?
Yes, one piece of advice that you'd like to share for folks who are listening as we embark on the collective journey to build a more equitable healthcare delivery system.
Yeah, that's what I thought. So, what we've tried to do is what I would advise others is hire, and I think someone said it in the comments as well, hire Black and people of color, hire people that might be marginalized by the results of bias to help upstream create the models. That is probably the most direct thing that we can do to bring those perspectives into the creation of the actual product. We can bring empathy to the table and try to, or bring sympathy to the table or try to bring understanding to the table, but true empathy comes for people that have experienced bias and inequity in their own lives. And these professionals that are coming to the table, that especially the newer generation that want to change the world, are really the best people to focus on and not just the usual suspects. And that includes also a socioeconomic marginalization. You know, some of the best schools in the world a lot of times are the resumes that make it to the top. And we need to look at state schools. We need to look at people that can, not just from the data science point of view, but again, from the social science point of view, can represent.
Thank you, John. And definitely an important point, and one that I think we all can get behind. Tina, I'll pass to you, and then we can do Web, Shiv.
Yeah, so I completely agree with John. It's about stakeholder involvement and really having the diversity on the team. So when you're looking at a product, you need to understand, you know, who's been involved in developing the project, but also, you know, what question are they trying to answer? You know, that's really important. What question are they trying to answer? And is that question equally important to all populations? Right. And so, you know, one thing that we should need to think about where healthcare is moving is to telehealth. And it's going to be really a prominent piece of our healthcare moving forward. So how do we think about understanding biases, inequities, and this aspect in telehealth? And are the right people at the table to develop the right questions we need to ask, to develop the right quality measures we need to think about, and to really develop the standards that we want to move forward with in something like telehealth? So really, it's stakeholder involvement and understanding the question.
Tina, I think you opened up a whole other can of worms, which is like, how does this manifest in a virtual environment as opposed to in person? And I think that's definitely a topic for another day. Maybe we'll get the gang back together. I'll pass to Webb.
I'll piggyback onto John and Tina's comments. I think absolutely who's working on it matters. Absolutely the use case, you know, the questions they're trying to answer matter. And I think obviously I've been pretty emphatic in saying this, the approach and the assets that they're using to power their analytics is really foundational to the success. And so, you know, the observations I'll share there are that, you know, having spent a decade in this space, despite all the advances in health tech, the right insights and recommendations aren't making it to impact the patients who need it most. And our core belief is that you need to be able to see as complete a picture as possible regarding what's happening across the entirety of the healthcare system in order to identify and proactively address gaps in care delivery to optimize patient outcomes. And I will say this, hopefully it's an encouraging, you know, final point from me. As data continues to proliferate and advance, it's been hard to get the whole picture, but it is possible.
Thank you, Webb. Thank you so much. And with that, we've got just 2 minutes left. We'll pass to Shiv.
Not too much that I can add really to everything that's been said. But I think, Morgan, you mentioned investors, and that sort of reminded me of one of our investors who sort of, when we first started the company, told us that they really believed that trust is the most powerful network effect. And, you know, from any sort of entity's perspective, really thinking about trust from day zero can be such a huge differentiator. And it won't be cheap, but it will be worth it. And so if trust is some combination of transparency, of reliability, of credibility, I think one thing that we can all do together, everybody who's really trying to push this, is to work together and be transparent and share our findings and publish and really collaborate. And so I take a lot of inspiration from my co-founder, Sandeep, who really spearheaded our efforts at Abridge to think about equity by design principles from day zero, and to publish the work and to put it all out there so that we can hopefully build trust over time. So yeah, I think at the end of the day, that's I think what machine learning in healthcare really needs to find a way to build.
Couldn't agree with that more, and thank you for that, Shiv. So that concludes our panel for today. Thank you again to our panelists, and we'll pass it back to Med City.
Thank you so much, Morgan. Thank you, Tina. Thank you, Webb, Shiv, and John. This was a really, really interesting discussion, and it's an intractable problem, but at least hearing from you, it seemed like there is some hope out there. I can only personally think of how much things have changed even over the last couple of years We had a gentleman from a very prominent Midwest health system, not the Mayo Clinic, a few years ago, who said that providing transportation and housing and nutrition is not really the job of a health system. And now that institution is providing high-speed internet to underserved populations. So change is happening, not as fast as we would like, but it is happening. So again, great discussion. Thank you all. And I hope to see some of you back at 3:30 Eastern. We'll have our pitch contest with the medical devices track. So thank you again for a great discussion and talk soon.